Hey, Jerry Pal listeners. Before we start this podcast, we'd just like to say a very brief thank you to all of those who've recently donated more than $100 to the Jerry Pal podcast, including
Trisha Goshi, Paul Tatum, Brian Castle, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Samoji, Matthew Schuster, Carrie Hagan, and Lloyd Woolstadt.
And if you're interested in donating, just go to the Jerry Pal website and click that blue donate button. And it's a tax
deductible,
nonprofit.
Yep.
All that fun stuff. And on to the show. Welcome to the Jerry Pal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, we have three amazing guests to talk about palliative care and nursing home settings. Who do we have on the podcast with us today?
We are delighted to welcome back Kathleen Unroe, who is a geriatrician and palliative care doc and researcher and a professor of medicine at Indiana University and founder and CEO of Probari. Kathleen, welcome back to the Jerry Pal podcast.
Thank you.
And we're delighted to welcome Cari Levy, who is a geriatrician, palliative care doc, researcher, and professor of medicine at the University of Colorado. Cari, welcome to the Jerry Pal podcast.
Thank you. Very happy to be here.
And we're delighted to welcome Connie Cole, who is a nurse researcher and assistant professor at the University of Colorado. Connie, welcome to the Jerry Pal podcast.
Thank you for having me.
So we got a lot to talk about palliative care and nursing home settings, from specialty to primary palliative care to hospice, the barriers, what's working, the solutions. But before we do, I think someone has a song request for Alex.
I would like to request Hallelujah, one of my favorite songs, and I love hearing you sing. And so it's an excuse to have you sing a beautiful song. And it's I think, a very uplifting song. And I'm so pleased with Connie and that she's doing so well. And so it's a celebration of her too.
Okay, I got a question for you. Who is your favorite singer of the song?
Leonard Cohen.
Leonard Cohen.
Oh, okay.
That's
Well, oops, I learned the Jeff Buckley version.
Oh, that's okay. No problem.
I won't do my growl. I won't try to change it up quickly to do my growly Leonard Cohen voice version. All right, here's a little bit. I heard there was a secret chord that David played and it pleased the Lord, but you don't really care for music, do ya? Well, it goes like this: the fourth, the fifth, the minor fall, and the major lift, the baffled king composing hallelujah, hallelujah. Hallelujah, hallelujah, hallelujah.
That was wonderful, Alex.
Such
Beautiful.
a beautiful song. Thank you so much.
Thank you.
So we have a lot to talk about, but I'm wondering if we can kind of take a big step back and just talk about the patient population that's in nursing homes. Like, do they have palliative care needs? And if so, what do we think they are? Anyone want to take that first gander? That's a big question.
Well, I think any of us who've spent any time in nursing homes have spent time working in a nursing home setting, have visited, had family members in nursing homes, and looked around and seen the population there. You know, the reason that you're in a nursing home is because you have some mix of serious illness and, multi-morbidity, usually functional impairments. You need help with very basic activities, getting to the bathroom, getting dressed, and memory issues, cognitive impairment. And so as you think about the conditions that mean that you need care and support in a nursing home, it's easy to see why many of us feel that there are a lot of palliative care needs of nursing home residents just because of the nature of the conditions and reasons that got you there.
When I think about, we are the Jerry Pal podcast, and you think about geriatric palliative care, you think nursing homes ought to be the paradigmatic, location, an exemplar of, the combination of geriatrics and palliative care. And yet, it's been so hard to integrate palliative care into nursing homes. Why is that? Cari, Connie, why is that?
Well, what I was going to say right before you mentioned that is that when I first started working in nursing homes, I was shocked by the focus on rehab. Of course, rehab is an important piece, but the majority of what's being done, unless you're exclusively a rehab facility, is geri palliative care, right? And so it was always a bit of a frustration, and that's why I got started in the area, because my hope was to equip those who are already practicing in that environment with the primary palliative care skills and frankly, primary geriatric skills as well. And you see the need. And so I do think it might be shifting a bit where people recognize the importance of this environment for care, as we all have more and more of our loved ones and our patients in this environment for longer term care. So I think because of the financial pull, there's always been this focus on rehab. And my hope is that, as you explain, this is a place where you do the final phase of life really, really well. It should be. It should be that.
Connie, can I ask you, how did you get interested in this as a subject?
So I've been a clinician working in the nursing home since back in the 80s. And I saw a lot of patients that really needed palliative care. And as I was getting ready to go to grad school.
And can I ask, what were you seeing when you saw that need for palliative care? What did that look like to you?
Well, so as I was getting ready for grad school and trying to figure out what to study, I had one patient who had been admitted to the nursing home under hospice. She was expected to die in the next couple of days, but she actually got better. And eventually, they call it graduated from hospice. I'm not sure that's the best term to use, but she spent over 6 months on hospice. She improved. So eventually they took her off of hospice, and she had a lot of pain.
Yeah.
Her hands, her feet, she had some really severe neuropathy, and it affected her so much. She was so depressed. And so I tried to get her actually to pain management, and I couldn't. Pain management wouldn't come to the facility, and she was bedbound. So it took us a long time to be able to get her pain under control. And so it really got me interested in how we improve symptom management, not just pain, but symptom management then for people that are in a nursing home and that can't go out for specialty care all the time, like pain management. So we see a lot of problems with symptom management, a lot of family conflict.
And what I'm hearing as far as needs is, I think half of the nursing home population has a type of dementia, cognitive impairment.
Yes.
Alex, I'm going to go way back in your memory bank. Alex actually was I think, senior author. Ann Kelly was a first author, I believe, of hospice or not nursing home length of stay. I think it was like back in 2010 at the end of life. Do you remember what that found, Alex? Let's see if I can trigger Alex's.
Lengths of stay were pretty short in nursing homes. So most people think, oh, I got to save in case I have to go into a nursing home and I'm going to be in there for a long time. And there's like that long tail of some people who are in there. But among people who die in nursing homes, the length of stay was actually short. Now that
5 months, median length of stay, 5 months. Median was 5 months, and the mean I think was like 13 or somewhere around there.
And dear listeners, this is ancient history, so I'm sure there's been some more recent data, or somebody out there should study it.
Do we know of any other recent data out there around prognosis, length of stay for newly admitted or decedents of long-term care? Does that sound about right to y'all?
I think the most recent I've seen is that they generally, most don't live throughout a year.
Yeah.
A third die within the first year.
And I think right now the trend is assisted living, and the assisted living facilities are doing a lot of end of life care, interestingly enough. And so I think there's over time a shift for fewer people to go to a nursing home for that level of care.
I always think about the assisted living facility as it's like the rich person's nursing home, where does that seem like a reasonable short?
Well, nursing homes are a safety net, right? So nursing homes are covered by Medicaid, and assisted living is only covered by Medicaid in some circumstances and some states, and there can be a waiting list. So yes, the population in assisted living is more likely to be self-pay. It is intended to be a continuum of care, and assisted living doesn't offer the same level of medical supportive services as nursing homes. And so if someone with increasing needs is staying in that setting, they're likely bringing in additional support, potentially through hospice. And there is a lot of use of hospice and assisted living, but also potentially privately hiring aid care as well. But to come back to just nursing homes, when you think about what a nursing home is and the range of people that they take care of, you can see why it's so tricky to think about how do we get the right services in there. So it's, nursing homes are part of the healthcare sector, but they're also part of the social care sector. In the same building, if you have 100 beds in the building, 20 of them today might be rehab. People who are there, and I think the median length of stay in a facility for rehab is around 17 days, something like that. And so they're in there for a very short time, couple weeks, get a little bit stronger and transition home after a hospitalization. Those other 80 people are there for real varying lengths of stay, but they're there for long-term supportive care and end of life care for as long as that might be. So it's sort of inherently challenging, this system that we've built and we've created in the United States, to think about all the right mix of services that you need to get in there. But Connie, your point about how you wanted someone to come there, right? The services need to be in the building, I think, is an important one to talk about, because people in nursing homes do have a lot of medical issues. And so they're going out to see a cardiologist, they're going out to see, potentially another specialist or a surgeon. But we do a lot of care in the facility. And so we do have consultants who come in the building, and I mean, you want to talk about that, like kind of what we're trying to do in the facility, what kind of skills we need to have or we need to bring into the facility.
Well, was that a question for someone, or is that?
I was thinking, I was kind of throwing it, Connie. I don't know. I keep thinking about your resident and all those days, right? You described all those days where you were trying to, you were working with the team in the building, trying to get this woman support, and she was suffering. She was in pain. And so there are some services that are so important. We need to bring them in-house.
Connie, you practice in nursing homes. Do specialists actually go into nursing homes?
Some specialists do. So hospice, I consider a specialty, and they come into nursing. And you do have like podiatry that comes in. Some psychiatric services come into the nursing home. So you do see some specialists come into
wound care. Yeah. And geri psych. Yeah.
As far as like a cardiologist, no. You do see palliative care. So we do have like palliative care through home health agencies that will come in and see patients.
And when you say palliative care, what does that look like? Is that like a palliative care trained doctor, NP, a pharmacist, a social worker? Like, what does that part look like?
So generally what I see very rural is a nurse practitioner that's out of our local home health and hospice agency that is palliative care certified. And usually it's simply for a consult. It usually isn't for continuing palliative care services. So usually they'll make recommendations, maybe some medication adjustments or something like that. And then the provider that's caring for them in-house will take over from there.
The idea there is they already have a social worker in the facility, right? So they've got support services available within the facility. So the palliative care service doesn't necessarily need to provide those.
Potentially, right? Like that there is something to a palliative care trained social worker. I mean, it's like they already have a doctor. Sure. Do they need a palliative care doctor or nurse practitioner if they already have a nurse practitioner or doctor in the nursing home?
Who's going to pay for that, though? I mean, back to Cari's, what Cari was talking about financial barriers to palliative care services in the nursing home setting. I don't know of codes that when you think of the team approach to palliative care, NPs and MDs can bill Medicare for, the same codes that we use for primary care, E&M codes, but I don't know of codes that the other members of the team can use in nursing homes.
So there's financial disincentives for interdisciplinary palliative care teams. What do we know about? Go ahead, Alex.
Well, I guess I'd beg the question, like, to what extent do we need specialized palliative care in the nursing homes as opposed to building up the primary palliative care skills of the providers who are already in the nursing homes?
Connie has thought a lot about that.
Yeah.
More than
Connie, what do you
That-
think?
that-
I mean, there's a workforce
Question.
shortage of palliative care providers. We can't possibly provide enough care to all people with serious illness. And if we take on all nursing home residents or even just those who are most seriously ill, I don't think we'd have enough. I mean, how do we make this work?
I think we need both. So I do think that we need to make the case for primary palliative care in nursing homes, and that we need to improve the ability of the providers that are there to provide basic palliative care. So basic pain management, goals of care conversations. But I do think there is still room where we need specialist palliative care. There's maybe some complex situations with family that takes some navigating around. And I could foresee conversations around maybe palliative sedation that a primary care provider would not be comfortable with at all. So I think the line is we need to figure out where that falls and how we differentiate between those different needs.
And some of the work Connie's doing is to try to figure out who are those people that really
Yeah.
would benefit from specialty palliative care. Yeah.
Well, I want to talk about that. But before we jump into like what does that process of referrals look like and how can we improve it? Do we have any data on like how many nursing homes have specialty palliative care access? Use of hospice in nursing homes? Anything like that?
I think what we have is a little dated, but Kathleen, I'll let you jump in here too. But since COVID, things have changed a little bit in the nursing home. And
So this is a trickier question than it should be. And so there's 16,000 nursing homes. Almost all of them have hospice contracts. And, some relationship with hospice. Some might not do many referrals at all to hospice. Some will have stronger relationships with hospice. So that part we know.
And I think like almost 50% of nursing home decedents utilize hospice, and that number has grown over the last 2 decades. Does that sound about right to you too? Like,
Yeah.
Utilization
Yes,
of hospice has increased pretty well. What about specialty palliative care? Is that a black box?
There's some work I'm thinking of Susan Miller's work that's tried to identify palliative care providers and then see if they're billing in the nursing home setting of care to characterize this. But it's actually difficult to tell because there are different ways that people deliver palliative care in the nursing home setting. And, Connie, I think you highlighted one where a nurse practitioner coming from a home health agency. Some hospices are providing non-hospice palliative care consults in the same nursing home where they have hospice residents. But I think that it is happening though, and it's not well characterized, but it is happening. And that's some of what, Connie, your work has tried to capture, is trying to understand how this is working now. Like trying to because it's just, there's what's happening in practice and our research and the science behind it, and trying to understand what's happening now, where the gaps are, and how we can move forward in a more structured way. But, Connie, you've talked to people who are doing palliative care consults right now, and I think have learned a lot about what this looks like in practice in terms of referral processes. Yeah, and you've talked to some nurse practitioners, haven't you, working in this setting?
Yeah, so I did. I did actually a series of qualitative interviews, talking to staff and nurse practitioners that work in this setting and that work in hospice and palliative care. And it is difficult. There isn't really a standardized method for when they need palliative care or when they need hospice, and what that even looks like. From one nursing facility, palliative care program may look completely different to a palliative care program in another facility. Yeah.
And so you have 2 papers that came out, one in JAGS on identifying palliative care needs, and another one in Journal of Applied Gerontology, looking at that referral process and what does that referral process look like. Can you describe that one, that referral process to palliative care, what you learned from that qualitative data?
Yeah. So in that one, we interviewed 17 providers and nursing home staff to try and figure out what that referral process actually looked like. And what we found was it was pretty much a 4-step process. And first was we had to identify which patients or which residents would benefit from palliative care.
And how'd they do that?
And a lot of times they weren't doing that. So the staff weren't looking. A lot of times the nurse practitioners indicated that the staff were very task focused. And in the staff defense, they have a lot that they're trying to do. They're trying to give medication to a number of patients. And the staffing shortages in nursing home have really gotten kind of crazy. So they were a lot of preoccupied with other tasks.
But clinical gestalt, right, Connie?
Yeah.
It wasn't a structured process. When they do identify residents, it was, it wasn't clear criteria. It didn't seem like from.
So there's no structured criteria that they're using. It was just, feels like the right type of patient.
Needed a goals of care discussion, or there was a general sense they were declining. Sorry, Connie, go ahead.
That's right. I was going to say that even some of them that I interviewed didn't know there was a difference between palliative care and hospice. So They conflated the two and thought that they needed, the 6-month remaining in their lifespan before they would refer them. Yeah. And there was some misinformation there.
And that kind of goes to your JAGS article where you looked at the nursing home palliative care needs, goals of care support, uncontrolled symptoms, serious illness, global indicators of decline, and end-of-life care as reasons, right? Reasons why people thought about consulting palliative care. So that first step, which is resident identification.
Right. And this is kind of where I've taken my research direction.
Yeah. So what happened after? So this referral process, 4 steps. First one is you got to find out who the resident is. What's that next step?
So the next step was generally trying to assess whether they were eligible for palliative care. And that came down a lot of times to asking the provider whether they felt they met criteria, and then also looking to see if they had the financial, like the proper insurance or things like that, because facilities were mistakenly, or I guess conflating the hospice benefit with palliative care. Yeah. Because when you're on a SNF stay, hospice is also a Part A, and so there's a problem with the payment.
Yeah. Mm-hmm.
And so a lot of times nursing home providers or the nursing home would much rather financially incentived to have that patient stay in a SNF stay versus transition to hospice. And then there's also some financial benefit for the patient as well if they have to pay for room and board. But yeah, so the next step was trying to make sure they were eligible.
Yeah.
For those services.
And Kathleen, Cari, do you want to talk any more about that financial barrier, that hospice? I think Alex, you wrote about this too, the rehab to death.
Rehab to death, yeah, sure. I mean, the way it's structured, right, is if you need rehab, if you qualify for rehab, Medicare will pay for 20 days in a nursing home, in a SNF, for a SNF stay. And if you decide, gosh, I don't think that's actually my goal, I'd rather go to the facility and, begin hospice once I arrive. Well, you've just added 20 days at a cost of $300 to $500 a day. And that's a lot of money, because now the Medicare benefit won't pay for your room and board because you're receiving hospice, you're not receiving rehab. So there's a big incentive to do a rehab stay. And a lot of people will say, well, let me give it a try. Let me see if I will bounce back in that time. And then if I don't, maybe we'll transition to long-term care. But there is that initial incentive. And then, of course, the facility is making more money while you're on a SNF stay than if you're there for long-term care. So those are some driving forces. And then I just wanted to mention one other thing that I was thinking about when Connie was talking, which is that a lot of people in nursing homes die of, general decline, but you can't certify someone for hospice when they're generally declining. So it does become a little bit difficult in that setting. Kathleen, sorry.
Oh, no, I was just going to affirm the only time that Medicare is paying for nursing homes is in that post-acute hospitalization rehab context. Medicaid is who pays for most nursing home bed days. So if you do not have Medicaid and you go into a nursing home for supportive care on the hospice benefit, that family is paying for it. out of pocket. So it's both a facility and a patient incentive to transition from the hospital, use your Medicare benefit to pay for that care. There's other financial incentives at play. If you have a long stay resident who's likely on Medicaid and they transition to hospice, there's a pass through of the Medicaid daily payment that goes through the hospice agency and then to the nursing home. So the nursing home's not getting directly paid. So there's a delay. And sometimes some of that money, I think almost always some of that money is, taken off for the hospice to do that service. So there's a few financial, disincentives to providing hospice care in nursing homes.
And if they're on Medicaid, short stay versus there for hospice, the nursing home gets more money if they're there for short stay rehab or skilled.
Oh, yes. Medicare reimburses at a higher daily rate than Medicaid. Yes.
Much higher.
And we should mention that one of the great things the VA has done is to provide payment for room and board in a nursing home facility for veterans who are on hospice. And I think that's a terrific match for that population of veterans who are dying, who are often lack the means to pay for room and board. And boy, wouldn't it be great if that kind of service was part of the Medicare hospice benefit as well.
No question about it. We did a study a number of years ago looking at that. And, I think the worry would be, oh gosh, people will use this benefit, a lot. In fact, it's not used a lot. It's a very, I think, appropriate amount that people end up using that particular benefit. And it's amazing. I work in the VA and we have somebody who doesn't have the finances to support a stay in a nursing home and they're on hospice. And it's such a relief to family and to the providers and the patient, of course, to be able to go receive the care you need and receive hospice. And I think in many cases in the VA, we avoid that rehab stay that's really to get a few free days in a nursing home because everybody knows this person's not going to be able to rehab because we've got this other benefit.
Well, I was just going to say, I think that there are a lot of strategies to optimize hospice use in nursing homes, and some of them are policy and regulatory fixes. But to Cari's point about how it is difficult, even with someone with advanced dementia, to know how long they're going to live, that can lead to delays in accessing the hospice benefit. There are also people who, hospice, they would never choose to change over to hospice. It's not going to be acceptable to them. And then there's also people who really, potentially your person, Connie, who transitioned off of the hospice benefit, she may have lived for another couple of years, but with significant symptoms. So I think that fundamentally hospice will not meet all the palliative care needs, even if optimized in the nursing home population, which is why it's so important to wrap our minds around how we can do this. What are the different pathways? There's more than one to do this in this setting, to do palliative care more broadly in this setting.
Okay, so I want to get to that, how to do it, but let's finish off the 4 steps. So the first step for palliative care referrals is you identify the resident. We talked about the barriers to that. Any solutions to that, by the way?
To identifying residents?
Yeah, besides using a structured tool, I think you mentioned using the MDS nurses. So, by the way, what is an MDS nurse?
Okay. So in the nursing home setting, you have required assessments that occur on a regular basis. Generally, they're quarterly or with any change of condition. And they're real comprehensive assessments. So they'll include cognition, their ADLs, incontinence, disease process. So very, very comprehensive assessments. And they're required on a quarterly basis. And they're supposed to drive care planning. So they take the results from those assessments and they complete their care plan and they decide on their goals. But since those assessments are comprehensive, the MDS nurse, which is, they're called minimum data set assessments. So the nurse that fills these out on a regular basis was identified as a person that is ideally positioned in the nursing home setting that would already be conducting assessments and would have really deep knowledge what these patients' needs are. that they would be a really good place to do some kind of structured screening for palliative care needs.
Oh, that's beautiful. MDS 4.0 right there.
Yeah.
Okay, so
That's
you
right.
identify the resident, you assess for eligibility. Consensus building is third step in this palliative care referral process that you wrote in this journal, Applied Gerontology, which I'll have a link to in our show notes. What was consensus building?
So, and I want to clarify too, some of the buildings actually reversed step 2 and 3. So sometimes, but generally it was in this order. So consensus building was trying to, what a lot of people called getting everyone on the same page. So there's a lot of barriers to palliative and hospice care because people can conflate the two. And they think when you go on to hospice or palliative care that you're just generally going to die in the next, days, weeks, hours. And so there was a lot of misconceptions around palliative care. And so bringing information to people that says, we think that your parent or your mom or your dad, meets the criteria and would benefit from a palliative care consult can really set someone aback that's not ready for that information. And if they conflate that with hospice care, the consensus building step was along the lines of talking then with providers, talking with families, talking with patients, and then deciding on a course of action.
And then the fourth step was consultation.
And then the fourth step was actually trying to get the consultation once the need was identified and the consensus was reached. And this was still problematic.
Why?
Particularly for people with dementia. And it's like Kathleen noted, most of the time you would have to send someone out of the building. You'd have to get transportation arranged, and you would have to take them to an outpatient visit, which is very, very difficult, particularly for people with dementia. There's not a lot of palliative care specialists that actually go to a nursing home. So that was one of the largest barriers in the actual obtaining the consultation.
Are there people looking into how to improve specialty palliative care consultations in nursing homes?
Kathleen?
I mean, absolutely. So part of it is it has to make sense. Like it has to make sense in terms of, can you bill for it? You're going to drive all the way to this nursing home. Are you going to see multiple people there? Do you have a panel of residents that you're following? And breaking down this process is so important, because if we can work on the identification part of it, and if we could even automate the identification part, and if we could provide, this is why it has to be, like Connie said, like we need to enhance capacity in the nursing home, the level of knowledge, understanding what palliative care can offer, et cetera, to kind of make some of those other steps move through a little faster. But yes, I think that we have to work on the business model part of it, and the evidence-based part of it, and then we can get more palliative care providers in there. But they need to know they'll be impactful, and they need to know they'll be welcomed and accepted, and that they will have enough residents there to make it make sense to drive there.
What about telehealth?
It's so tough. We tried to do this during the pandemic, and you would think it would be easier than it is. But
you got people there who
you got people there.
We can do it in people's homes. Why can't we do it in?
Right.
Caroline Stevens does some of this. And
yes,
I know Lynn Flinton, who's a frequent guest host of this podcast, was actually one of the interventionists in her studies. Is like would be the palliative care doc who's looking on a screen and being wheeled into somebody's room on a monitor.
Right. So it makes perfect sense. But I'll tell you that the barriers that we've run into are, number one, the iPads, disappear and they're hard to find. And there's all sorts of technical glitches and people get frustrated. The staff in nursing homes are busy. They are busy. They do not have capacity to do extra things. And so this takes time, and they need to know when to go in there, and that the clinician's going to be ready. And then there's hearing issues. That's probably the biggest thing, is that it's really tough for people to be able to hear the visit. And then with the high prevalence of dementia, you need a companion there to help often. And arranging that can be logistically tough. So there's definitely barriers.
But I feel like maybe there's solvable problems. I don't know. Here's the future. where you have
definitely solvable. Definitely.
Like an
I
robot.
haven't given up on it.
Yeah, you haven't given up. Like an AI robot goes in the room with the screen, and that links to the human palliative care provider and is also the companion. And then there's an assistive amplification device that the robot puts on the patient's ears.
Beautiful.
Or something like that. I don't know.
Beautiful.
And even a step before that could be, this is where we're talking about the multidisciplinary palliative care team. And I think that one of the hardest things anytime we're doing interventions in nursing homes is if we are asking the staff to do more things or different things than their usual workflow, we're already way behind.
Yep.
Like it's going to be a huge challenge. And so if we can send someone in there to help facilitate that side
like
of
a
it.
palliative navigator part of the team that like a palliative navigator, like a,
so I think they are solvable problems by human beings and by robots. So more to come, I'm sure.
It reminds me, this like idea that they're so crunched for time reminds me of I remember Cynthia Boyd did this in primary care, where she was like, okay, let's say you have a typical primary care visit for a complex older adult. And here are all of the things that guidelines say you should need to do. And here's how much time it takes to do them. And it's like, there's no way you could do that. And the nursing home staff are similarly like tasked with doing so many different things. Exactly. Like one of the reasons and the pushback against the primary palliative care in nursing homes is that they just can't do more.
There's no time.
Yeah, they're so short of time. But some of these things are addressable potentially through education.
Yeah, sure.
Well, on the other hand, like we had Lee Vandenblock, remember on that podcast in the Wayback Machine in Europe, who did that, multi-country study of primary palliative care, and no difference.
Yeah. Is there any evidence for primary palliative care? I mean, anywhere, but for this talk, like in nursing homes, that study was a hard no. And part of it, what I remember is like staff turnover. Even the people that you trained, like they'll go on to something else. Then you got to train more people. Then you got to train more people. And you got nursing homes in the U.S. have, 100% staff turnover over the course of the year.
Yeah.
I think turnover is a big problem in nursing homes. And that's why we need to do something to integrate it into workflow so that the new person coming on doesn't need as much training. So perhaps the EHR identifies flags someone that has palliative care needs and automatically shoots an email to the provider. So I think there's different ways that we can sidestep around some of that turnover and also sidestep some of the shortages that we see they're just so busy.
But the answer is not education, because if you educate this group that's there today, you'll have a completely new group 2 months from now.
Although they move to other nursing homes.
They do.
They
That's
move to other nursing homes.
But if you wish to improve things in this nursing home.
I know. Yeah. But they're often, the turnover rates are highly problematic and a fundamental issue in this setting. Often nursing homes have a core group of staff that they do retain. And I've heard administrators say, I wish you'd focus on retention rates because we're always going to have some turnover, but I try so hard to support staff and there are people who stay with me over time. So not everyone needs to be a palliative care expert in the facility, right? But I think there is some, there's sort of this fundamental knowledge base that's important around symptom assessment and then communicating that, et cetera. And then there need to be some key people with some palliative care knowledge. In terms of how it should look, it could differ by facilities. I think, Connie, sometimes appropriately, right? Because we have some facilities the medical director is board certified in palliative care. I think the residents there are likely fewer, because I think, Alex, you were asking about that. Like, how many people in this building really need a specialist? I'd say fewer in that one. And so that's, again, I think this is why this is challenging.
Yeah, it's a really tough nugget. Primary palliative care anywhere is a really tough nugget to crack, nursing homes in particular. But I like your point. Can we have maybe they're not specialists, but maybe, a certain few people who are retained longer become more specialized over time. I think what I remember from that European study is that those people were actually heavily recruited away from that nursing home because they have that expertise. And the other problem was the providers, the MDs, the MPs, they're hardly ever there in the nursing home. And communicating those recommendations is very difficult because you don't see them around.
Right. In one of our studies, we screened people for palliative care needs, and then we forwarded a consult request to the primary care doc for that patient. And that was the hardest part. And so we eventually just did an auto consult. We said, if we identify that this person needs consultation, can we just do it? And they eventually just let us do it because that back and forth was too clunky.
So I love all this discussion about kind of referrals, issues with primary and specialty palliative care. Kind of for each one of you, kind of how are you thinking about the next steps of what you're looking at in this population? Kathleen, I'll start with you.
So I am finishing a clinical trial of a specialty palliative care intervention called the Uplift Study. John Cagle at the University of Maryland is the MPI on that study. We've implemented this palliative care model in 16 nursing homes in Indiana and Maryland. So results to come within the next year from that study.
Oh, we're going to have you and John on.
Yeah.
I can't wait. Leva Vandenblock is a consultant on our study and has been really helpful in helping us build on what the work they did in their 8-country European.
Can you describe in a very, if you can describe, if it's not embargoed, what the intervention actually looked like? You don't have to talk about the results. Yes.
So the Uplift study is doing a mix of this educating staff, so they know the difference between hospice and palliative care, basics around symptom management, et cetera, identifying a champion within that building, but and having a structured referral process, and then having specialty consultants come in to see residents who are identified and do consults and do follow-up consults and follow them over time, a 1-year intervention period.
Oh, that's great.
Yeah.
Oh, we're going to have you back. Connie, what's next for you?
So I'm taking this research to the next step. I have a career development award waiting council next month. And and then I'm launching the study. It's called Timely Identifying Palliative Needs in Nursing Homes, TIPIN. And so we're going to build the evidence base for screening in nursing homes and implement it.
Oh, that's fabulous. And Cari?
Well, I think the solution really is largely what Kathleen's doing. You have an external group that's coming in because of the way that the nursing homes are struggling with staffing and things, and helping support them. The models that are most successful are where you're kind of co-locating and you're partnering with specialists and have a relationship there. And as far as the shortage of palliative care providers, we have a program here at University of Colorado that trains non-physicians to become proficient in palliative care. And it doesn't always have to be a doctor, right? It can be an APP, it can be a social worker, it can be a chaplain. There's many things that can be accomplished beyond, what we're used to seeing with a typical MD provider. And so I think that's the future, is that we've got more disciplines involved who can do this type of consultation and do the goals of care discussions. And, maybe they're not the symptom management folks, but they have the other skill sets. So I think that's where we'll see some success.
And last question, Cari, Kathleen, either one of you, I see a lot of research studies out there. Oftentimes, nursing home patients are not included in those, maybe explicitly excluded from those studies.
Yes.
It seems like doing research in nursing homes, either people don't care or it's too hard. Is there any thought about how we can improve that going forward in the future?
Absolutely. There are a number of implementation challenges that, unless you test it in a nursing home setting, you're not going to navigate it. You're not going to figure out those solutions and do that hard work. And the lack of studies in this setting creates delays in getting evidence-based therapies and treatments to nursing home residents. And I think we saw that writ large during the pandemic. The NIA has invested in a U24 called the Next Steps Project, which I lead out of Indiana University with a large group of colleagues, including Cari, who's a leader on that project. And the whole goal of it is to enhance and expand the number of explanatory clinical trials in the nursing home setting. We have a pilot projects program that Cari leads that we just had our first round, and we're so excited to review the many applications we got. And we're working hard to create all kinds of guidelines, templates, here's how you set up agreements with nursing homes and directly address those barriers that people have encountered. I have found it a very rewarding place to do research, and I'm so excited that Connie, you're building your career working in this setting where you have such a passion as well. And I think there's a lot of good work to be done, and we can figure it out.
Hallelujah to that.
Yeah. Well, can I add one more quick thing?
You should.
Eric, can I add one more really quick thing?
Yeah, go ahead, Cari.
So we've started a living lab where we have residents at facilities as a part of an academic research advisory council, where we bring research projects to them and say, hey, do you think this is appropriate for your community? And we have amazing attendance. The interest from residents on this is over the top. So I will just say that there is incredible interest on the resident side. And so I think that's where we have a lot of opportunity, is with the residents. The staff are busy, but the residents would love to engage with research.
That was worth the break to my transition to the Hallelujah song. So thank you for adding that.
Well, your faith was strong, but you needed proof. You saw her bathing on the roof, her broody in the moonlight overthrew you. She tied you to her kitchen chair, she broke your throne, she cut your hair, and from your lips she drew the hallelujah. Hallelujah. Hallelujah, hallelujah, hallelujah.
Kathleen, Connie, Cari, thank you for joining on this podcast, and thank you for all the research that you're doing on this.
Thank you for
Having us.
Thank you, Alex.
And thank you to all of our listeners for your continued support. We'd also like to say a big thank you to those who've donated more than $250 to the Geriatrics podcast over the last year, including
Anna Lynch, Deborah and Jeffrey Larson, Krista Mossack, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordowski, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, Paul Amatelli, Brian Castle, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Samoji, Matthew Schuster, Carrie Hagan, and Lloyd Woolstadt.
a very big thank you. And if you too want to donate to the Cherry Pal podcast, please go to the Cherry Pal website and click on the blue or orange donate button.